the task of trying to convince you guys that glenoid reconstruction with distal tibial allograft is an excellent choice for glenoid bone loss. And as Michael has mentioned, that glenoid bone loss is a very strong and increasingly recognized factor in recurrent anterior and not only posterior glenohumeral stability following surgical stabilization. And although historically we kind of classified 20 to 25% of glenoid bone loss as being critical, where if glenoid bone loss is not primarily addressed, that number actually has been borne out to be lower, even as low as 13.5% by John Tokish's group. So Charlie just tried to give you this big spin presentation that, you know, arthroscopy is the state of the art. If we restore the capsulolabral junction, if we add a little sprinkle of remplissage, everything is going to be fine and there will be no recurrent instability. But this is real life stuff. This is fresh off the presses. I saw this athlete 5 weeks ago, 18-year-old football linebacker who's transferred to us from the University of Alabama, who's had recurrent instability. He's failed 2 arthroscopic stabilizations within 2 years. The first one was done by his local orthopedic surgeon where they performed, like Charlie mentioned, a nice arthroscopic procedure. And it didn't stop there. He had recurrent instability. The provider, who was a very well-known shoulder surgeon down in Alabama, decided to do the same thing and did a revision arthroscopic anterior and posterior labral reconstruction and listened to one of Charlie's talks and added a little remplissage. And what you can see is the sequelae of that. So in the top 2 pictures, you can see actually the patient has significantly diminished glenohumeral joint space, but I think this is a false view because this does not necessarily represent glenohumeral osteoarthritis. It's actually his humeral head sitting on the anterior glenoid loss